Dawn Martin. I'm the chair of the PEB board. And I am going to go ahead and do a roll call to get us started. So let's start with Vice Chair Dawn Mottner. I can see you.
Good morning, present. She,
Thanks,
her,
Dawn.
Ega.
Thank you, Dawn. Greg Klauser. Greg, are you here yet? My guess is Greg will be joining us.
Good morning.
Oh, you are here. Hello.
Yeah. My computer is messing up, so once I get it fixed, I will switch over, but I'm here on the phone for now.
Sounds good. Thanks, Greg.
Thank you.
All right, Andy. Morning.
I am present.
And Kimberly, saw you too.
I'm
There
here.
you are.
I'm here.
Hello.
Good morning.
Good morning. Kate, are you with us this morning?
Good morning, I'm here.
Great. Hello, Kate. Sean.
Here. Good morning.
Morning, Sean. And Representative Nose.
Good morning, present.
Great. So it's good to see all of you. I do have exciting news that we have filled the management vacancy on the board, and we will welcome her when she comes. Her name is Cheeky Flowers. She's the director of the Oregon Health Insurance Marketplace. Very exciting that she's joining us.
That's a great choice.
She has had to, change her schedule around because she just got confirmed recently. We expect her around 10 o'clock, so maybe we can pause between presentations and welcome her when she joins. The other thing I will tell folks now, and I'll try to remind again at the end of the meeting, our November meeting is our retreat date that's going to be in person. For those of you who remember when we used to meet in person pre-pandemic, we would meet at that OHA office in Salem. That's where we'll be, or that's the plan, that's my understanding. So those details will come out in November. But I did want to remind folks that it's been a long time since we've been in person, and we'll get to see each other in person next month.
I'm sorry, I'll have to miss it. I will not be around for the retreat.
Oh, that's too bad. Sorry to hear that. All right, so I'm going to move us to our first order of business, which is approving the minutes from our September meeting. Rose did send out some updated minutes this morning, or no, I'm sorry, last evening. I saw them again this morning, and she did a couple of corrections for those who read the minutes early. I think they're good to go, so I would appreciate a motion to approve the minutes. I have a motion.
This is Kimberly. I'd make a motion to approve the minutes as revised and sent out by Rose last night.
Great, thank you, Kimberly. Do I have a second?
I'll second. This is Andy.
Great, thank you, Andy. All right, so Dawn, how do you vote?
To approve.
Thank you. Greg?
I approve.
You, Andy? Oh, you seconded. So Kimberly, and you did the first. Kate, how do you vote?
I approve.
Thank you. And Sean?
Approve.
All right, so the minutes are approved from our September meeting. Thank you, everyone. So our first presentation today is around the hospital cap that we have spent a lot of time looking at, and it's really exciting that we have this report today to hear about how it's been working. So I'm turning it over, it looks like, to Brad Lawson and Lynn Evers. Go ahead. Thought I heard someone jumping in.
You know, I did
Greg.
jump in.
A computer as well.
Y'all couldn't hear me.
Oh, is that you, Brian? Oh, no, sorry. Is this Brad?
Is Brad. Yeah.
Hi, Brad. Go ahead.
No, I had a great spiel going, and then I was just on mute. You know, I do that at least once a day. You got to love it. So I just wanted to say thank you to the board first for having us here. We always appreciate an opportunity to present. This is some really neat analysis and some great results that we have for you today. We can move on to the background slide, Rose. That would be great. And just dive right in. We don't have a lot of time, so I'm going to move fairly quickly through these slides. I think next slide. All right. So, if you have questions, please feel free to step in. I'm happy to discuss as long as the board will have us, but I think we're scheduled just for 20 minutes, and there's a lot of material to get through in here. So, really quick, and first, a bit of background. Recall that the law was signed into effect in 2017 and effective for the 2020 plan years for both the OEB and PEB boards. In 2021, WTW performed an audit analysis to assure compliance with the law and evaluate savings and the results of the legislation. And after completion of that audit, it was decided that the boards would like to refresh that in 2022 after a full calendar year of 2021 was available and reflecting the clarified rules which were implemented in late December of 2020. So kind of just a little background there. We can move on to the next slide. And a little bit of housekeeping here. We have some disclosures to make. Facility data that we used in this analysis was provided directly by the carriers. And, while we have reviewed it for reasonableness and consistency and so on, we have not performed an extensive audit analysis on the data in there. And second, it's important to recall that while the law applies at an admission level, we do measure compliance at a hospital level. And that means that any overpayments are allowed to be offset by underpayments. So as we go through this analysis, you'll notice those two terms in there. Did I see a question come up or a hand or something? Okay. Maybe a stretch. And then finally, kind of at the bottom here, we do have a little bit of a compliance requirement. The benchmarking data that we use at the end of the report is based on analysis and data from Meritive, which used to be our old market scan. It's licensed by WTW, and we have noted a number of restrictions around the use of that data as you move forward with this analysis. Any questions on that? Otherwise, we can move to the results on page 6, which has kind of our high level summary. And, just as a spoiler alert, this is a great results of this report. Compliance results are very similar to the prior year results and analysis, with compliance demonstrated by.
Putting you on speaker. Hello?
Oh, hello. Oh, I think we have somebody that might not be muted. So kind of getting back to our results, compliance was demonstrated, by all carriers and at the hospital level, very similar to the prior year. And as expected, we did see improvements in estimated savings due to the implementation of the clarified rules and a combination of a return to more normal utilization patterns as we continued through the pandemic in 2021. So kind of at a little bit of a deeper level, outpatient savings were relatively consistent with the prior year, while we did see the most improvement in inpatient. Estimated savings, we can kind of see down here, increased from about 59 million in the 2020 plan year, all the way up to 112 million in the 2021 calendar year. So we've, shown some results in, back in 2018, we did some very high level estimating of about $81 million. And so we are certainly on track to exceed that. And that's really a combination of the clarified rules. I think the 1067 with those rules having a little bit more impact than we initially anticipated, as well as just general medical trend and things that's gone about through the last 4 or 5 years. From a benchmarking perspective, we've really improved our positions. Prior to the implementation of 1067, we were approximately 5% over benchmark, and this is just for facility claims recall. And based on this most recent calendar year 2021 analysis, we are now about 20% under benchmark. So just overall, very good results. And we'll look at a little bit of these in deeper detail as we move forward. In the meantime, any questions on these high-level kind of summary results? All right, so the next section, we'll move to slide 8. Thank you very much. So this section is a little bit deeper dive into the audit analysis. We'll focus a little more on the PEBB column, which is in the top chart in the right-hand side. PEBB had just a little bit over 202 million claims that were facility claims that were subject to 1067. And we see that, you know, in final results, we came in at about 161% of Medicare, which is well below the 200% threshold target that was established by 1067. When we looked at results on a per admission level, there were about $7 million of overpayments. But when we switch and we look at that at a by hospital level, which is how we measure our compliance, there was virtually no overpayments, only about $200,000. So very, very favorable results. You know, and that's really indicating that while there are overpayments and perhaps some opportunity to you know, work a little bit more with the carriers, there's also underpayments, and those are really you know, largely offsetting each other, you know, in the analysis. You know, again, looking at on a carrier level, very, very similar results. The carrier analysis is combined for OEB and PEBB, but all carriers demonstrating very favorable results on a by hospital level. Any questions, comments, hurrahs? All right. Okay, we can move on to slide 9. And this is we're going to take a quick deep look into inpatient, and then we'll take a look at outpatient from a compliance perspective. So, you know, very, very high level and quick, we see that average reimbursement levels for the PEBB plan across all carriers were about 146% of Medicare for inpatient facility claims, which is very much below the 200% threshold, so very favorable results. We had not too many overpayments even on a by admission level at about 1.7 million. And when those are offset at a hospital level with underpayments, we are right about 0, you know, estimated overpayments by hospital. Very good results for the inpatient side. Any questions on inpatient before we take a very quick look at outpatient? All right, so moving on to slide 10, we can see that we do have a little bit higher reimbursement level for outpatient at 178%, but again, still lower than our 200% threshold. We did have a little bit higher overpayments on a by admission level at 5.3 million. But again, when we aggregate those down to a hospital level where underpayments are offsetting the overpayments, that drops to about $200,000 that we saw in aggregate earlier. So again, very favorable results. Okay. Any overall general questions, you know, from a compliance perspective, which was the purpose of that section? I think very favorable results, no concerns, and you know, the plan seems to be performing as intended. And we're getting a little bit of background noise. All right. Okay, so we can move on to slide 12. And this section is going to focus on the estimated savings of the plan, which I know was a lot of interest last year. We do have the current analysis on the left in kind of that pinkish color, and we have the prior year analysis, which is on a plan year basis on the right in kind of that purple color. Results are shown for this purpose combined for PEBB and OEB. If there's some interest in looking at the PEBB specific results, we certainly have that available too. But in total, the plans had about $340 million of allowed charges that were subject to 1067. You can find that down in that total row at the bottom in the very lower left-hand corner, with an estimated reimbursement pre-1067 of about 215% of Medicare. We see that following the implementation of those clarified rules in 2021, the reimbursement as a percent of Medicare dropped substantially to about 160%, and that drove our $112 million of estimated savings, which is approximately 33% of total facility costs. You know, looking at the kind of moving to the middle, so just one up from the total on the outpatient basis, we see that 1067 really had the largest impact, you know, between the two different categories, inpatient and outpatient, or we started at about 250% of Medicare and dropped all the way down to 180% of Medicare, 178. And that's driving the bulk of the savings at about 74 million, and was a substantial reduction of just a little over 40% of those outpatient facility claims. So very strong results there. However, when we move kind of the next one up and we look at inpatient, while our results aren't quite as strong, this category does show the real impact of moving from that prior year analysis to the current year analysis. Recall that last year when we walked through this, we started at 176% of Medicare. And then after the initial plan year, we actually had a bump up in facility costs to 180% of Medicare, which drove about $4.5 million of additional cost impact. Moving over to the left-hand side in the current year analysis, we see that pre-1067, very similar results estimated at about 175% if we had not implemented 1067. However, with 1067 and the clarified rules, that has now dropped to 140% and is driving just about $39 million of savings, which is about 24% from a pre-1067 estimate. So very, very good results and a reversal in that, going from that 180% down to 140%. And I think really clearly demonstrates the impact of the clarified rules, which the team worked very hard to get implemented in 2020. All right, any questions there? All right, we can move on to slide 13. We'll just spend just a half a second on this. This shows results by carrier, all of which showed savings increases from the prior to current year analysis. Unless there's any specific questions, we can move on to the next slide. All right, so this slide shows our estimated reimbursement by DRG, and just highlights some of the problem areas that we found last year. Again, in the dark purple, recall that there were a number of DRGs that were driving significant cost increases. We can see that I'm just going to reference them by number. The DRG code 793, 794 in particular, had very large increases going from 50 to 60% of Medicare pre-1067 to 140 to 160% of Medicare after 1067 was implemented. So I think this really shows that power of those clarified rules, which limited it to not just 200%, but the lesser of billed charges or contracted rates. And that did bring those back down from the 50, 60%, and you're back down to that level. And in fact, even below, now we're at a range of 36% of Medicare to 56% of Medicare. So bringing that down dramatically for both the 793 and the 794 year over year. And that's a good illustration of the power of those clarified rules and really what was driving our reversal of results for inpatient.
I have
Any
a question
questions?
about that.
Mm-hmm.
Yeah, please. Dawn Mautner, her AM Medicaid medical director. Thank you for this work. I will admit that I'm outside of my comfort zone for some of this, but maybe a good deal of this. But the question about, so what I'm seeing here is that the percents of Medicare reimbursement pre and post Senate Bill 1067 are for those DRGs considerably lower than the averages that we were seeing on the other slides.
Mm-hmm. That's correct. Yeah. On a percent of Medicare basis, maternity type, these are both neonate DRGs, don't get a tremendous amount of attention from Medicare, from a Medicare pricing perspective. And so I think those were largely driven more by a market perspective. The percent of Medicare, the Medicare reimbursement rates are probably not very well aligned with market, or maybe not consistently aligned with market compared to other inpatient type services. I don't know if it helps at all, but from a market perspective, what was happening is we had some contracted rates for those, but when you went over to the Medicare side, I think they were just mispriced, or they were priced generally for a service that may have been maybe a little higher severity or something, based on experience. It's not my area of expertise either. Looking at those very specific Medicare pricing categories. But the legislation as it was written, some of the providers were really pushing for a much higher reimbursement and submitting it at either a billed charge, which was much higher, or in fact even going all the way up and submitting it 200% of Medicare, and demanding that kind of payment as the legislation seemed to allow that. I know there's been debate on that back and forth as well, though.
Thanks. In cases like that, it makes it a little bit of a less useful comparison. It feels to me, it feels a little bit like apples and oranges, and it also makes me wonder how consistent are the other percentages when I'm trying to compare them along this column of pre and post, especially for specific DRGs. But I'll pull back and try to contextualize it there.
No, it's a really good comment. I think looking at these DRGs, when we were doing our preliminary analysis back in 2017, 18, 19, I think that the expectation would be that the legislation would not have an impact on these DRGs because they were not over 200% anyways. And so, I think that was a loophole, or I guess loophole is really just the best terminology to describe that was said, hey, some of the providers and, really read that legislation and said, hey, we think we can get away with increasing, the reimbursement on these, to help offset some of the decreases that we're seeing in other areas. So really that percent of Medicare it's not necessarily measuring what the right reimbursement level is. It's really just a very solid relativity measure to say if, everybody, Medicare is the same for everybody across the board, rather than looking at a discount or contracted rates based off of discounts from a charge master or something. So that percentage of Medicare is really just looking at just really looking at it as a kind of a relativity scale. I don't know if that helps at all, but it allows us to monitor how things are changing.
I just want to jump in. I know you're almost to your last slide. I mean, it is really incredible how the costs have been brought down, and just part of the overall strategy to keep costs under control. This is a really important tool. And I do think that this analysis around the loophole, and I know there's definitely been debate because, as being part of the board, I was frustrated when I saw these costs go up for the neonatal care, in particular. And so having this slide and seeing that, there was an audit done, we saw that we had to clarify the rule we didn't think we should have to clarify, but we did. And, the rates are back down. But overall, it really is just a huge success. And I think we should feel very good about, the strategy to put this rule into effect, because this impacts, PEBB and OEB impacts the state overall in terms of how much we're paying for healthcare, and how good our members' benefits can continue to be if we are keeping costs down. And Kate, I know you had a question. Go ahead.
And I may have missed this. So has there been major fluctuations in Medicare rates at all too? Because I mean, this is obviously relative to Medicare rates, and those are outside of our control. So what's going on in the overall Medicare rates compared to like growth or anything like that, given kind of the uncertainty around healthcare costs over the last couple of years with the pandemic?
Yeah, Medicare rates really haven't had a tremendous amount of volatility. They grow at, 3 to 5% per year, if that. Recall that they're you know, they go through a legislative process that has to, you know, have a very robust review and everything. So they really don't have a tremendous amount of variation. They're not subject to the contracting, you know, type constraints that a commercial plan has to do. They have to go out and do network contracting and face pressures and all these different types of things. So does that answer your question?
Yeah, it's just something I haven't really paid attention to over the course of the last 4 years, 3 years probably. I used to pay more attention to it, and so I just wanted to make sure I didn't miss something that happened with the pandemic and some of the other stuff that was going on with
No,
healthcare
totally,
costs. So,
totally
so I
fair
just wanted to
question.
make sure that that wasn't something we. Okay, no,
Yep,
so it totally
yep.
answered my question. Thank you.
Wonderful. I just want to point out to you that on a Medicare basis, that is a, you know, a cost per service that does not reflect changes in utilization and, you know, those kind of things that might have been pandemic impacted. Certainly, we had a lot of you know, elderly hospitalizations and impacts through the pandemic that would have been, you know, driving a lot of Medicare cost, but not necessarily the Medicare cost per service, which we're looking at here. Very good. Thank you for the questions. I know we're running just a hair bit over. If we want to slide down really quick, you know, from a benchmarking perspective, and I think we covered the core thing in you know, the core results in our executive summary. We can kind of slip right down into or up to, we see the PEBB results that are on the left-hand side, middle section. You know, we were at 217% pre-1067. If you look at that total line, we are now at 159%, which is a very big swing in a favorable direction. And our benchmark is right at 200% of Medicare, lower for inpatient, higher for outpatient. Yeah, question?
It's more just a request. At some point, when I get a little bit of downtime during the long session in the House Healthcare Committee, would I be able to have you come and share this? I think a lot of my colleagues would find this fascinating.
Yeah, I mean, I think, yeah, you know, feel free to coordinate with the boards and have them reach out. You know, we're happy to chat about that. And
it wouldn't be for at
to,
the rate we're going. It wouldn't be for so many months. But
okay.
I just think it's interesting to see that this was a controversial proposal, as you can imagine.
Oh yes.
And for a lot of reasons, and it's working.
Yes, it's the whole. I have always loved John's comment about the whack-a-mole. Sometimes you got to whack them down a little bit, but you know, close some of those loopholes. But in general, after 2 years of implementation, looks like it's been very effective in accomplishing what it was intended to do. All right. So I think, you know, we've already kind of done our summary on slide 17, and there's a number of different pieces in the appendix. If you're, you know, have trouble sleeping at night, you can read through methods and assumptions and so on. Otherwise, happy to take any last questions before we turn it back over.
All
All right,
well,
and yep,
Oh,
and
go
as
ahead.
always, if there's any questions, please feel free to reach out through the board, and we are happy to help and answer.
Thanks so much, Brad. And
Thank
again, exciting to see the success of this. So next, we're actually moving to our dental plans provider diversity discussion. And I believe we have Delta Dental presenting first with Terry Baricello. I don't know if I pronounced your last name correctly.
Good morning.
Good morning.
Great. Well,
Give it
thank
over
you
to you.
thank you. Thank you for having us here today to talk about this. Just by way of quick introduction, because I haven't presented to the PEBB board in some time. I'm Dr. Terry Baricello, and I am the Vice President and Chief Dental Officer for Delta Dental of Oregon and MODA. Just a little background prior to my role here. I was a general dentist in private practice in Oregon City for 13 years and have been with Delta Dental MODA for 11 years now. Actually in 2 days, it will be the anniversary of when I started, and time flies. So I'll go ahead and get right into the topic. If you don't mind advancing the slide, please. So really quick overview of what I want to talk about. I'm going to talk generally at a very high level about dental provider diversity, and then initiatives within the Delta system to increase workforce diversity. I'll touch on our provider search tool that we call Find Care to assist members in finding the right providers for them. And then I'll end with an overview of access of our dental networks in the state of Oregon. So go ahead and move on to the next slide. So I wanted to start again at a high level with sharing some national data on the diversity, or what you can probably see here is really the lack of diversity within the dentist workforce. So the charts on the slide before you come from an editorial published in the Journal of the American Dental Association last year. So in 5-year increments, it breaks down the racial distribution of the US population on the left side versus that of the dentist population on the right side. And we can see that the dental workforce does not mimic the US population overall in terms of racial distribution, not at any of the date slices. The dentist workforce consistently skews more Asian and white, and Hispanic and Black dentists are underrepresented significantly in comparison to the US population. It is interesting to note that the proportion of white dentists has declined a bit over time. However, that decline has not been made up by uniform diversification across all races and ethnicities. The proportion of dentists who are Black has not increased, while the share who are Hispanic and Asian has. And in fact, the data indicate that the changes in racial distribution have been driven almost entirely by a significant increase in Asian dentists. Go ahead and go to the next slide. So now let's look at what that distribution looks like here in Oregon. So this data is also from the American Dental Association. It was not published. It represents the entire dentist population in Oregon, not just members of the ADA or the Oregon Dental Association. But you can see a similar trend as to what was found in the national data, with the majority of the dentist workforce being white. Go ahead and go to the next slide. So the lack of diversity in the dental workforce is an issue that's getting attention across the industry, really at all levels, of course, at the payer side, especially within academia, within organized dentistry. So I wanted to highlight specifically some activities within the Delta system that are meant to drive more diversification in the dentist workforce. So first of all, driving greater diversity is now a specific Delta Dental Plans Association board initiative. We're really interested in pipeline development programs focused on minorities and underrepresented communities. DDPA has committed $1 million annually to establish the Oral Health Diversity Fund. This will invest in solutions and pilots, ideas that address barriers that many minority and underserved populations face, specifically to pursuing a career in the oral health workforce. And then through our Delta Dental Institute and in partnership with the American Association for Dental, Oral, and Craniofacial Research, we have established Oral Health Equity Research Awards to support research focused on greater oral health equity in populations that lack access to care, and improves oral health literacy for underserved populations. And then getting down to here in Oregon, Delta Dental of Oregon, we're really proud to be part of a broad coalition focused on addressing dental workforce issues. The coalition has submitted a legislative concept for the upcoming 2023 legislative session, and it's asking for funding for a wide variety of initiatives, and several of which have specific focus on support for students from diverse populations. And I want to note too that these initiatives, or this legislative concept, is not focused just on the dentist workforce, but across all slices. That would include dental assisting and hygiene too, which similarly lack diversification, and we have a workforce shortage in Oregon. Okay, go ahead and go to the next slide. So now I want to talk a little bit about the efforts we've been making internally to build out the ability for our members to search by the demographic attributes that may be relevant or important to them. So this has been ongoing for the last couple of years. And you can see before you and on the bullets the different attributes that now are searchable on our Find Care. But I want to talk a little bit about how we're going about getting this information, because it has been really challenging. So we began sending provider and clinic level surveys to all of our network dentists July of last year. And since that mailing, we have continued to provide and really promote the links to fill out those surveys. We have a quarterly newsletter that we have in all of our email signatures and interactions with our providers by email. We actually meet with our dental providers regularly in person and do office visits. We leave behind flyers with them. And we also actually called out, we did a query on including our PEBB membership, the highest utilized offices, and call them directly to try to encourage them to provide this information, because it's not required. But we have found that a lot of offices, I think COVID plays into it. They are not following through to the degree that is meaningful enough for our members to, have a robust look at in Find Care to find what they're looking for. So we've had a lot of challenges on our data collection. We've also, it's been expressed to us, there is some fear of discrimination with offices. So that's a challenge for my professional relations team to help them understand why we are capturing this information, why we're wanting to share this information. And then for some of our larger group practices, there have been organizational decisions to not participate. So we're working with their leadership to, again, try to help them understand the importance of why we're trying to capture this information. But we are continuing to look at different ways that we can, we can provide this for our members, and it will be, hopefully we'll have better results in about a year. But in all transparency, right now, our response rate is less than 5%. Okay, let's go ahead and go to the next slide and the next slide. So I was asked to talk a bit about our dental network access across the state. And I have to start with the fact that we're really proud of our access. Delta Dental of Oregon does have the largest dental network in the state. And we monitor and track access in a couple of different ways. So the first that you're going to see before you is by geo-access reporting. So this process maps where PEBB members reside by address in relationship to where we have contracted dental providers. And this report was run at the beginning of this month, so it's still very fresh. The map shows PEBB members with access as green dots on the map, and members without access as red dots. We use the CMS requirements for the ACA plans for what is determined to meet access, and those definitions are listed right there below the map. So for example, in large and metro areas, access means there's at least one provider within 30 miles of the member. The results of this mapping demonstrate robust access for dental providers for PEBB members. PEBB is on an active PPO plan design, which means members get the best discounts and their benefits go further when they see a PPO provider. And out of over 88,000 members, only 55 PEBB members don't meet the CMS standard for access to a PPO dentist. Our plan uses our Premier network, which is our larger network, as a wraparound. And you can see that when you include Premier, only 33 members don't meet the standard. The geomapping exercise also provides us the average distance to the first, second, and third closest providers, which you can see in the table on the bottom left. And the average distance to the third closest provider is 3.5 miles. It was shared with me that there's some interest specifically in the Southern Oregon areas of Coos and Curry counties and possibly Douglas counties. And I hope that the map in front of you gives you a quick visual as to our access in those areas. I also had my team look at them specifically, and I can answer questions if you have them around those areas, but we do have actually very good access in those counties per the CMS standards. But some of those areas, and we have every PEBB member by city where they're at, and there are some areas where they meet the standard, but admittedly it is with some distance to a provider. But they're very rural areas where a dentist right in their community is just not feasible. There's not enough population to sustain a dental practice. So I'll pause there and see if there's any questions.
No, I appreciate you highlighting the access in those counties. The issues coming up around access has been around Willamette Dental, and I know we're going to be hearing from them. We have not heard about access issues in regards to Delta Dental.
Thank you for that clarification. I appreciate it. Go ahead and go to the next slide. So the other way that we monitor access is by looking at claims utilization, which tells us where members are actually choosing to receive their care. So based on claims from July of last year through June of this year, nearly 98% of PEBB members' claims are coming from in-network providers. So that, I hope, really underscores that we have very broad access here. But to put it in perspective and kind of benchmark it, according to P&R Dental Strategies, which is a dental analytics company who maintain a multi-payer database, they have an arsenal of claims from over 70 regional and national payers. So in 2021 and through August of 2022, the average percentage of claims that processes in network was 79%. So the PEBB performance is far exceeding that. And then go ahead and go to the next slide. So while we are really proud of our network strength, we, for my professional relations team, we know that the job is never done. We really have two primary goals in that department. One is to make sure that we maintain the relationships that we have with our contracted dentists. And then we also work very hard to recruit those who are not yet contracted. We do that through a few different ways. Number one, and one of the most powerful ways we have is that we get nominations from members if they are seeing an out-of-network dentist. And that, as a, putting my practitioner hat on, there's nothing more powerful than having my own patient advocate to say, hey, would you do this for me? Like, I have a relationship with you. Can you consider joining this network? I can absolutely say that was very effective in my own decision-making when I was in practice. So we get provider nominations and we'll go to the office and work with them personally to let them know that patients in their practice have specifically recommended them for recruitment. As I mentioned before, we are one of the very few, if not only, third-party payers that actually go out in person and visit our dentists to try to problem solve any of the pain points that they have. And we also do targeted outreach for non-participating providers at that time. Another thing that we do that is very unique, we provide provider workshops annually in multiple areas. And then, of course, during COVID, we built out an entire webinar capability as well to walk providers through any new changes, particularly around codes and the way that we process claims, around predeterminations. So we provide a lot of provider education that is really powerful to that retention side. Our relationship with our dentist is of primary importance. Actually, in my own job description, it's one of my prime and key responsibilities, something that we really take seriously here. So that is the final slide. I'm happy to take any other questions that there may be.
Do you have any questions for the doctor? All right, really appreciate this information. Thank you so much.
Yeah, thank you so much.
All right, so we will be hearing from Willamette Dental next. And we have, I'm not sure whether we've got Mark Chambers presenting. We have a few folks, Nick Sports, Tiffany Nicholson, and I may be pronouncing people's last names wrong. Sorry about that.
No worries. Good morning. Thanks so much for having us. So I am Tiffany Nicholson. I am the key account executive that supports the PEBB accounts. And presenting with me today is going to be Dr. Nick Skirties. He's the vice president of Willamette Dental and also the executive sponsor of our DEI committee, as well as Dr. Mark Chambers, who is our director of clinical operations. And Dr. Skirties is going to start us off with diversity, equity, and inclusion.
Thank you, Tiffany. Just wanted to say thanks to everyone for having us kind of talking through our DEI work that we have been implementing over the past several years. Kind of wanted to include what is our primary aim, and what we're trying to look to do is to build diversity, equity, and inclusion into the fabric of the company's culture. And we kind of talk as an organization, what is the aim and purpose of that? And for our employees, what we want is that each of the individuals are able to show up in their full identity and feel as if when they're coming to work, they're coming as their whole self. And we're doing that just kind of as an employee-based measure. And in doing so, the intention then is us as healthcare providers, what is our primary mission is to be able to deliver care, equitable care to all of our patients. And so that begins with having a workforce that reflects that. And so over the past couple of years, we've been able to implement affinity groups throughout the organization. And I'll kind of go to the next slide from here. And it actually talks about it on the next slide, but I'll come back to it. And so what we've been doing with the affinity groups is that as we go through, we've tried to incorporate each of our team members to participate. And this past year, we have a 43% increase in employee membership. These are relatively new members, and what we've been trying to do is that for each of the affinity groups, have them participate and create the identity of the group internally. So we don't go through as an organization and say to any of the affinity groups, here's an outline as to what the expectations are. We want each of the groups to be able to kind of put in a position where they're able to identify for themselves what it is that is of primary importance, whether or not it's training, whether or not it is participating in community events. And so as they begin to develop over time, it is our intention to kind of help just grow and allow for them to take a natural approach, organic approach to their integration with the organization. We've also added DEI questions to our employee satisfaction survey. We have a 88% return rate on our employee satisfaction survey annually. And so kind of incorporating diversity, equity, inclusion questions into the fabric of the organization so that we're able to keep a pulse as to what the perception and how we're working with the team. And we'll go back. For our provider profiles, every one of our doctors have biographies, pictures, language spoken. We have, over the past couple of years, had a higher increase in focus in our recruitment of diversity for our doctors in particular. In 2020, we created in perpetuity a grant with the Portland Community College to train 3 to 6 dental assistants every year. And one of the primary aims of that $1 million grant was to focus on individuals from socioeconomic circles that we could help better integrate into the dental community. This past 6 months, we were just awarded a $750,000 grant from the Oregon Health Authority to work on training dental assistants with a primary aim, again, diversity, equity, inclusion, and helping improve not only the individuals who are able to kind of get through the initial barriers of entering into the dental workforce, but then also creating career pathways of growth for dental assistants into dental assistant restorative roles, hygiene roles, so that they have career advancement opportunities. And we'll move to 2 slides from here. I'm going to keep everyone on their toes just by moving back and forth on the slides, so appreciate it. As you can kind of go through and see, thank you to Delta Dental for presenting earlier just what the national landscape was looking like. Here's kind of a more role-specific to Willamette and then kind of broken out from PEBB. So, relatively similar in certain regards. I think PEBB has reporting where it's not specified at a 34% rate. So kind of a little bit more difficult to drill down, but we have 26 languages spoken at Willamette. Going through for each of our patients, all of them have accessibility to services so that they're able to have a individual there at their appointment or via telephone to help translate. And we'll go to the next slide.
Excellent. So, as Dr. Skirties shared, if you look at that patient population of PEB, we have a diverse patient population, and with a diverse patient population comes some patients that need support with interpretive services, and we strive to do this with on-site translation services, but also telephonic translation services. As patients call in to our appointment center, to member services or patient financial services, all of these translation services are also made available to patients. The most common language that we see being requested for translation services is actually that of the Spanish language. And Dr. Skirty shared with you that we have 26 different languages that are actually spoken by our clinicians. I know in the clinic I work in, we have a doctor that speaks Albanian and we have a doctor that speaks Spanish. And there have been several times where I've been close by and heard one of my docs talk or speak Spanish with a Spanish speaking patient. And just what an incredible benefit that is for a clinician to speak in the patient's native tongue. Also, we talked about those clinicians in terms of those interpretive services that have been requested by patients or needed by patients. We've actually been able to provide 40% of those interactions by our staff that we have, our clinicians that we have at the clinics. And we've been very deliberate and intentional as we are recruiting new clinicians to find a real diverse clinician base and to recruit those clinicians in to aids in interpretive services, also aids in making it a better experience for our patients. Moving on to the next slide. As was discussed earlier, access is a concern. Since COVID, nationwide, there has been a clinician shortage in dentistry. And that clinician shortage, as you're aware, has led to more difficulty in patients or scheduling availability for patients. The American Dental Association in August of 2022 did a study and found that the average wait time for a new patient appointment, and this is nationwide, was 24 days. We compare that with Willamette Dental Group. Our average wait time in the state of Oregon has been 26 days over this time. And I can tell you, we are not content, nor are we happy with 26 days. That is a longer wait than what we want. The executive team for Willamette meets on a weekly basis. And as that executive team meets, their top agenda item that they have had over this time has been access and improving access for our patients. And that is important to delivering good care to our patients. Other things, we have a doctor, so a dentist, who is on call 24 hours a day, 7 days a week. The doctors rotate through and take turns. 2 weeks ago, I was on call and it was my turn. So I'd see patients during the day and I would receive phone calls sometimes in the middle of the night, sometimes during dinner, different times with patients calling in with more emergent needs. And so we have clinicians, we have dentists there to help take care of those patients when they have a toothache, with the goal that we're going to get patients in for an emergency appointment within 24 to 48 hours. And I know if I had a family member or a friend, I would had a toothache, I'd get them in that set of time as well. Tiffany, if you want to talk about next slide.
Yeah, thank you, Dr. Chambers. So we were asked to kind of provide a quick update on our Roseburg closure. So I think this has kind of been a hot topic coming up for our members. And so we just kind of wanted to address it and answer any questions that we can. So just to kind of provide a little bit of background, we have had continuous challenges recruiting dentist coverage for our Roseburg office for over 1.5 years, which has resulted in some reduced patient availability as well as member frustration. So after much consideration, a decision has been made and communicated back in early August to close our Roseburg office effective December 31st of this year. Members who typically access the Roseburg office, they can transition their care to any Willamette Dental Group office if they choose. The nearest offices to Roseburg are going to be found in Springfield and Eugene to the north, and then Grants Pass and Medford to the south. Dr. Wynn, who is currently practicing in our Roseburg location, will be transferring his practice over to Eugene, and if current members would like to continue to see him, they may do so. Now, we do recognize the circumstances and effect that this closure poses, both with enrollment challenges as well as an inconvenience to PEBB and our patients. We also recognize that members may not want to retain their Willamette dental coverage due to the distance from Roseburg to our Eugene, Grants Pass, or Medford offices. And I'm hoping that those open enrollment decisions, they do have time to make those. So for members currently in orthodontic treatments that will not be completed by the end of this year, and that maybe do not want to retain their Willamette dental coverage effective 1/1, we do have a few options for continuing their care at their current insurance benefit level so that there is no increased out-of-pocket costs for those services that have already started treatment. So some of those options, our members may continue to see Dr. Wyatter, who is the current Roseburg orthodontist, to finish their treatments, and they would follow him to the Medford office to do that treatment. They could also transfer their care to our orthodontist at our Springfield office, Dr. Reddy. And then we're also going to contracts and current negotiations are in place with a local orthodontic provider in Roseburg. So members that wish to finish that treatment locally will have that option to do so. In all of these scenarios, we will honor the existing insurance coverage so the orthodontia treatment can be completed as if their current Willamette dental insurance was active. So this will be extended to active ortho patients choosing to complete treatment with either an external provider or if they choose to continue their treatment with Dr. Wyatter in Medford or Dr. Reddy in Springfield. So honoring this coverage just means that patients will still have that office visit copay at each ortho appointment, and then maintaining those payment plans on their ortho payment plan if there is a balance. So Dr. Wyatter at the Roseburg office and his team have been communicating these options to all affected patients. And I've received recent feedback that majority are wanting to complete treatment with Willamette Dental in Medford or Springfield at this time. So all affected members have been notified of the Roseburg office closure, whether that was via email if we have it on file and that's their preferred communication method, or via letter through the post office. So this notification went out in the beginning of August, again, to ensure that members could make informed decisions during upcoming open enrollments. And this decision was not made lightly, and we do value our relationship with each of our patients. Next slide, please. So Mercer did ask for us to address a few additional questions in regards to possibility of some new locations. So we currently do not have any plans to open a new location in the Roseburg office, in the Roseburg area. Again, that's just due to the recruiting challenges that we have been faced over the last few years. We also currently do not have any plans to open any new locations in Douglas, Coos, or Curry County. Willamette Dental does not define our service area or have an eligibility rule, so members may obtain care at any of our locations regardless of the distance that their zip code may be from the closest office. This heat map on the right-hand side of the slide is an evaluation of our current membership, and we know that our members do and will travel to access care. So on the heat map, it'll show there that members in Central and Southern Oregon are willing to travel between 60 to 130 miles to our nearest office. And then some members traveling 90 to 130 miles in rural areas that may access our Richland office up in Washington, as well as some of our clinics across the Idaho border. So geographically speaking, the Roseburg closure will affect a smaller population of PEB members in comparison to other rural areas where PEB members are established, again, being Richlands, Medford, Grants Pass, and then our Boise, Idaho area offices. We are building a new office in Nampa, Idaho, and do anticipate that members in Eastern Oregon will choose to access care at this office, as currently there's about 3.5% of PEB patients that have established care in our Idaho offices. Next slide. I think that kind of formally wraps up our presentation, and we'll open it up for any questions at this time.
Go ahead, Greg.
Hello, I'm Greg Clauser, and I'm from Umatilla, which is just south of your Pasco office, or your Richland office. One of the questions in all of your data here, was that just Oregon, or was that individuals from PEB in Oregon that go to your offices?
In the heat map?
Right, because so I know in Portland, I know where I'm at, we have individuals who are in PEB, but they also live out of the state. So my question is those individuals are residents of the state or PEB members?
So those are actually our active patients. So not specific to PEB, but our entire Willamette patients.
Okay, and then the numbers prior as to how many you serve, where you serve, those were the same. Those were just active members when the doctor was talking about the numbers previously.
I'm sorry.
You were talking about the 24 days, or sorry, 26 days average access.
Yeah, the basic access to the what, is that?
Yeah, those were all Oregon patients. So going to our Oregon offices.
Okay, just Oregon offices is what I was getting at. Yeah, so we do have quite a few. I know because of Portland being so close, the Idaho offices and our Tri-Cities offices, would be kind of interesting to see if those numbers kind of match in those outlying areas.
Yeah, and I think Idaho is in a much better condition in comparison to Oregon, where I believe their access is about 17 days on average. Does that sound right, Dr. Chambers? Your office specifically might be different.
Yeah, Idaho has significantly better access than the state of Oregon currently.
And then Washington and on average is around 22.
Cool. Well, thank you.
And yeah, thanks for pointing that out. We should have included that, given that we do have PEB members utilizing.
I've been a Willamette, not that I need. I've been a Willamette member for a long time, and the Pasco or the Richland office has kind of went up and down, but lately it's doing very well. So thank you for that.
Good to hear. Thank you, Greg.
All right. Well, thank you so much. I do have a couple of comments that I just want to make around access to Willamette that I want the board to be thinking about. I know we're going to have some public comment today. We know we had some people concerned in the Coos, Curry, Douglas County areas of the state, some of whom had been accessing the Douglas or the Roseburg office from Coos County. And so just we need to keep in mind that at this point, for some folks to see a dental provider closer to home, they just have one option since Kaiser doesn't serve that area of the state when they're making their choices. And that's something that we need to keep in mind around plan design as well, because there's differences in plan design and cost comes up for our members. So that's something as we move into our decisions for the 2024 plan year, we're going to need to talk about. We also, we've had a conversation with Mercer to help us think about how do we handle anything for 2023 when we have people who are struggling with access. And this is coming up, and we'll hear in public comment around VSP services as well. And I know that's not on the agenda for today to hear from them, but just want to make sure folks are thinking about that and appreciate the presentation from Willamette Dental. And then also I learned that our new board member has joined us, Cheeky Flowers, and I would like to give her a moment to introduce herself and say welcome to the board. Cheeky.
Good morning, everybody. Just wanted to do a quick sound check. I've been having some device difficulties this morning.
Sounds great. Good morning, everybody. I am Chicky Flowers. My pronouns are she, her, and hers, and also Shakanya. Today on your video, I am wearing a gray camisole with a black cardigan over it. I am the director of the Oregon Health Insurance Marketplace. That you might know that as the Oregon Health Insurance Exchange, or previously also known as Cover Oregon. I've been with the Marketplace/Oregon Exchange since 2013 in various capacities, moving from project manager to COFA Premium Assistance Program, and then finally the administrator or director of the Marketplace since 2017. We formally joined OHA in 2021. I have to look at my calendar because the years go by as you work in the state, especially in the Marketplace. We joined the OHA in 2021. We are now officially part of the Health Policy and Analytics Division, now under Ali, who is our interim director. Happy to be part of the PEBB board. I officially joined, I think, a couple of weeks ago. Rose, I promise I will try to memorize the minutes, at least the notes, try to get caught up to speed as much as possible before the in-person retreat next month. It is a steep learning curve, I am sure, but I'm up to the task. Thanks for having me.
Thank you so much, and it's great to have you join us. So we are moving to the Kaiser Dental presentation, and I know we're a little bit behind agenda, but you should also get your 15 minutes. So I want to let you know that. And I am turning it over to, looks like, Daniel Filstrom.
Well, good morning, everyone. Can you hear me, first of all? Great.
Yes.
And fantastic. Santo, are you with us?
Yep. You're there.
All right. Sounds like we're all here. My name's Dan Pilstrom, general dentist at the Cedar Hills office and dental director for evidence-based practice. And Santo, I'm going to let you introduce yourself.
And I'm Santo Graziano, the director of operations for our dental program.
Good to be here with you all, and enjoyed the previous presenters, and we're going to piggyback on to many of those topics. So let's advance to the next slide. Santo, do you want to cover this one?
Yeah, so right now we have 21 offices. Our footprint goes from Longview, Washington, and as far south as Eugene, Oregon. We have 162 dentists working in our offices there. Over to the right, you see we have 4 offices that actually have LPNs embedded inside of them, and that's for our medical dental integration program. One of those things where we're able to close some of the medical care gaps for members as they're coming in and seeing our dentist by the nurse. So I think we can move to our next one.
Before we move on, let me just, one of the other, you guys have been talking a little about service expansion and areas. You know, for us and our footprint, this is we're very tied to what the medical organization is doing in terms of expansion. So this is our footprint. I will say that this year we are experimenting with a partnership with Northwest Teams International and contracting 51 mobile. You might have seen their mobile healthcare vans and doing chronic disease outreach to at-risk populations, including dental. So it's a way for us to try to get into more rural areas to see members. So I'll just mention that, but we're kind of a different entity in terms of our ability to expand because we're very tied to what's going on in the medical group and membership there.
All right, thank you, Dan.
Mm-hmm.
Our next on access and service. So right now you can see that we're at about 3.7 weeks for hygiene access and about 5 weeks for our general dentist access. We break those out a little bit separately because there's different services sub-services that can be provided within those areas. So the other thing that we've moved to is our scheduling tickets. And that's been something where we can push out whenever someone is due for their appointment and simplify the process of scheduling. They can simply click on it, potentially schedule straight through kp.org. That way when they're due, or if they were to choose to call in. We'll talk a little bit more about some of those conveniences and technology that we're trying to make that appointing process a little bit better as we go through here. And then, you know, we've heard from our others and you know, Kaiser Permanente is not immune either to some of the challenges that there are around staffing right now. And one of those areas that we're really focused on is dental assistants. And so, you know, similar to Willamette, we've partnered with PCC We have students coming through that program where we're giving full scholarships and then a job opportunity upon graduation. So that's something that we are trying to do and trying to increase our relationships with other schools and programs so that we can really help recruit people into the dental profession. And one of the ways that we're doing that is through community outreach. So most of the folks going into the program that we're providing scholarship for are ones from underserved communities where we've done outreach, tried to find folks who are in need of a job or, you know, recent move to the United States or other things, and we have to work through a lot to get them able to get into a PCC program, but it's very rewarding and just an additional pipeline that we have for talent. All right. And on our next slide, I'll talk about some of the convenient ways that we're trying to provide access. So one is this Fast Pass where, you know, we'll send a text or email message to members whenever they're on a wait list and there's an opportunity for an earlier appointment. It's pretty innovative. It goes out, it is first come, first serve. So that text message is going out to any patient on the wait list for that specific, you know, office or provider when an earlier appointment's opening up, and then they can click through and schedule that if it's available for them. We've moved to options for check-in to meet whatever the member's need is. So there's your standard normal check-in with a person at registration. We have kiosks in several of our offices, and then we have an express remote check-in option which allows you to actually do it all by phone if that's your preference and zero human contact. So we're trying to provide those options depending on whatever our patients really want and personalize that. For patients that don't have Kaiser Permanente Medical, they now have access on kp.org. So that's an enhancement that we've made. Giving them the ability to look at their medical record or their dental record, see the notes from their visit, any follow-up, and all the details right there on our app, along with scheduling. We talked a little bit about our online scheduling, and so a lot of that is push notice. So when you're due, that you'd be receiving that notice and then able to just click on it and move to what open appointments. Works really well whenever we've rolled that out slowly this year. But I think we now have every site up on that. And then a lot of different things such as hygiene, general dentistry, endodontics, pediatric, and orthodontic services all being all having those dental appointment tickets now. And then virtual dentistry. So, you know, when COVID started, that was one of the innovations that came about. So we have a dental advice team along with the on-call dentist that's available for those consults. And that's something where, you know, we have that available at no additional cost to our members, along with our 24/7, you know, phone advice and the way to do it through email or other things. Similar to what we've done in medical, there is looking at the e-triage options as well for dental so that they'd have that ability. So that will be coming in the future as well to work through a triage on the line. All right. Let's talk about our health equity at Kaiser Permanente.
And I think I'll take this one initially, Santo. So I think others in the group, Dr. Chambers and Dr. Skirties and Terry, also Dr. Botticelli, brought up just the importance of, you know, meeting our patients where they're at. And if we're going to be effective in our care and welcoming a diverse population, then our staff and dentists need to reflect that kind of diversity. And one of the ways that we do that is through language services. And I'm really proud of the fact that Kaiser Permanente has such great resources around non-English speaking patients and our ability to connect with them so that they understand the care that we're proposing. It wasn't a PEBB member, but I'll just share a brief story. Had a appointment last week where we had a woman that spoke a indigenous dialect from her home country of Guatemala, and her son was with her who did not speak English but spoke his mother's language and knew Spanish. And then we had an interpreter on an iPad that was speaking Spanish, and I was the provider. And let me tell you, the interpreting and the consent and all that took longer than the dental procedure, but everyone was heard and understood what was going on. So it is getting more complicated out there in terms of providing care, but it is the right thing to do. And I'm happy to say that we have the resources to do it, and the sort of the, I guess, the drive to engage in it in our teams.
Thank you, Dan. So some future programs that we have, we're starting up a Black Center of Excellence within our medical group on the East Interstate campus. So that's in North Portland there. And dental will become part of that no later than Q4 of 2023. So that will be integrated in that, having a process to screen and provide dental care to patients who may not have otherwise scheduled a dental appointment or maybe outreach themselves. So just another safety net opportunity within our medical dental integration and ability to do that. And another piece of that is really our diabetic members. And some of that goes down to different populations and some of the outreach that we can do to assist them through dental. And so with MDI, that's one where our diabetic members are much more likely whenever they've connected with the dentist and care team, and they're encouraging them, let's get your A1C done today, or others, that they actually follow through in getting that done. And we're looking at ways to integrate that. Within our medical group, we have 7 Salud en Español modules throughout the region, in a way that we might be able to do, similar to our plans for the Black Center of Excellence, some dental screening within the medical team there, just as another avenue for touching base with that population if they haven't been into our dental offices, and making sure that they're getting the screening and then getting connected if needed for their dental care. Social determinants of health, program-wide with Kaiser Permanente, so medical and dental now. This is something that all patients are getting screened on at least annually, and then connecting them with resources. So that's things where we're focused on financial hardships, food insecurity, housing instability, and transportation. Some of those very things that might prevent them from coming in and getting care that they need. And, we've implemented in dental on September 5th, and I've started doing that. So now it's all of Kaiser Permanente as a whole doing that screening. And we still offer financial assistance of $2,000 per year for our members. So with household income no greater than 300% of our federal poverty level. So we've talked a bit about medical dental integration, and I just highlight some of the positive things that our team's done. So last year we gave 5,000 flu vaccines. We're giving them again right now in several of our dental offices, where our dentist or LPNs are assisting in giving those. Our dentist and some hygienists gave 1,600 COVID-19 vaccines last year. So again, we're part of that whole picture of care for you. And they've closed 70,000 care gaps, medical care gaps through the dental office last year. 8,700 diabetic members had their care gaps closed that came in through our dental doors. So some outstanding work that we're doing to try to close all the gaps for care and make it easier for our members.
Fantastic. Thanks, Santo. And this is just a kind of an update on what our workforce in terms of the dentists look like. Orange is Oregon Dentists at Large, and blue is Permanente Dental Associates. And again, I'll say it again, if we're going to be successful at welcoming diverse populations of patients into our offices, then we have to have a diverse workforce. And it's such a critical part of getting it right in terms of care. So I'm really proud of the fact that we are a very diverse workforce. And Willamette mentioned the diversity, equity, inclusion, and the B for belonging, and that's a key part too. And that's part of the retention of our staff, because one of the things that all of the carriers are realizing is that if we don't have enough staff in the offices to take care of our patients, then we'll have access problems. And one of the ways that we can deal with that is by creating a culture of belonging in the offices to retain staff for their whole careers. And I think that might be our last slide, Santo. So if there are questions, we welcome them.
Great, I'm not seeing any questions. Appreciate your update and all of your initiatives. I also see that there's information in the appendix as well. So thank you to all of our dental carriers for presenting today. And we are going to go on a 10-minute break. And it's 10:54. I'm going to say we'll start again at 11:05, and I'll put that in the chat. All right, welcome back, everyone. Thank you for being ready to go. So looks like we're first going to be hearing from Mercer, and Kendra Lofgren, you're going to be presenting. Is that right?
That's correct.
All right, I'll hand it over to you. Thank you.
Great, thank you. Well, good morning, everyone. It's a pleasure to be here. My name's Kendra Lofgren. I'm a pharmacist and I head up the West Market pharmacy practice for the Mercer RX team. With me this morning also is Janine Statt, who's also a pharmacist. She is with our government consulting practice. She's going to join me a little bit later in the presentation to go over some PEBB specific information involving gene therapy forecasting. So with that, if we can move the slide forward, please. Thank you. So there are three things this morning I'd like to cover with the group. Historically, I've been doing these now for a couple of years, and we like to come in and just provide a nice update on the most important things that are happening in the pharmacy marketplace. We'll start with just a quick update on some things that we're seeing in the retail pharmacy space, some evolution that's happening there. Then we're going to touch on two really important areas that are going to become more visible for PEBB and all other employers in the marketplace. The first has to do with biosimilar therapies. And we've talked about these a little bit in the past, really coming to the forefront now. And then an update on those very high cost gene and cellular therapies that everyone I know is continuing to watch and is always concerned about from a cost management perspective. So if we move forward, and you can go forward again. So let's take a moment and talk about what's happening in the world of retail pharmacy and pharmacy services in general. We've really seen a change out in the marketplace regarding the visibility of pharmacy and specifically of pharmacists and their role in the larger healthcare delivery system. Specifically, when COVID hit, we really saw that pharmacists were really probably one of the more easily accessible healthcare providers in the healthcare space. And so it's been interesting to watch what's occurred since COVID really kind of hit its peak and now, is tapered off, that pharmacy's role has continued to expand. It really has been a catalyst for more pharmacist presence and interaction with patients. In particular, we've seen that, pharmacist prescribing has now come forth where pharmacists are able to prescribe Paxlovid, for instance, which is used for COVID treatments. If within those first 5 days of a positive test, and that's really kind of opened up quicker access to therapies around COVID. The other place where pharmacists have really played an instrumental role is in the vaccination network, and we've really seen a big increase in a push, actually, even from providers encouraging their patients and employers encouraging their members to utilize, retail pharmacy networks to obtain their vaccinations. And we're seeing a lot of those communications ramp up again, especially this time of year now that we have the bivalent COVID boosters. And we also, have flu vaccination time coming forth again. So, pharmacy is just continuing to evolve, and how pharmacists are engaging with members, the digital therapy, digital technology, capabilities that are there for pharmacists to utilize. It's just an ever-changing environment. And on this slide, you can look in more detail. There's just so many ways where pharmacy is touching healthcare delivery in new and unique ways. So we expect that to continue. and retail pharmacy chains in general are also changing their delivery model. So we're seeing a lot of that happening in conjunction with these expanded roles that pharmacists are playing out in the marketplace. So if you can move forward, please. And again, so now I'm going to transition and really talk about biosimilar therapies. This is really, biosimilars have been around in the marketplace for a few years now. However, it really is an emerging class of medications, and it's really an opportunity for plan sponsors because the high cost specialty medications where biosimilars can compete with those existing products at a reduced price, really offering savings to the plan as well as to members. It really is increasing the interest in how biosimilars are going to be woven into the coverage strategies around plans and what that's going to look like financially for plans as well. There are also some contract implications to consider because this is a new emerging area and really developing more on the outpatient side now through the pharmacy benefit, more so than availability of these products through the medical specialty benefit. It is really kind of causing employers to need to take a look at their existing pharmacy contracts and making sure that the contracts aren't silent in regard to how biosimilars are going to be priced, how they're going to be, what the strategies are, and whether or not rebates, whether that be on the medical side or the pharmacy side, are going to be available to the plan. So there's really a call to kind of take some action. And I'm going to talk in a moment here, especially with some of the things that are going to be happening throughout the calendar year of 2023. So if you move to the next slide, please. Thank you. So before I start talking in more detail about biosimilar and generics and how those compare, biosimilars is kind of a new term for a lot of people. Most people, I think, are more familiar with generics, which are lower cost versions of traditional drugs, whereas biosimilars are more a copy of a biologic drug. They're manufactured in a living system. The active ingredients are similar, but from an approval standpoint, they're different in that they have no clinically meaningful differences, which that means that the treatment outcome for the condition that the biosimilar is going to treat is comparable to that of the originator or the innovator product. So there are some, if you think about it, if you're familiar with the idea of generic drugs versus brand name drugs and providing cost savings to plans and cost savings to members, those types of philosophies apply with regards to biosimilars versus brand name specialty drugs as well. Although there is one biosimilar insulin, which is not a specialty drug, that is available on the marketplace today. But primarily, we're seeing the biosimilars really coming forth in the specialty drug space and presenting a real opportunity. There are some headwinds for biosimilars a little bit, because they do have to go through an interchangeability review with the FDA if they want to be able to be prescribed and have the ability for pharmacists to directly substitute the biosimilar for a specialty drug. Interchangeability approval isn't a requirement. They just need to show, but isn't a requirement, but it's desirable because of the ability of pharmacists to automatically substitute a biosimilar when an interchangeability approval has been received. If an interchangeability approval hasn't been received, then that would mean that the prescriber would have to actually issue the prescription for the biosimilar's name specifically. If the brand name drug was written and there was not an interchangeability approval, it would mean that the pharmacist would have to go back to the physician and have a discussion and get an approval in order to dispense the biosimilar, which would be typically at a lower cost than the brand name product. So there's a lot of savings opportunity here. Not necessarily to the same magnitude as traditional generic drugs, but certainly when you look at the average cost of the brand name specialty drugs being, upwards of $35,000 to $4,000 on average, and you look at a savings potential of 10 to 37%, that's still significant to the plan and significant to the member should there be any deductibles or out of pocket, that sort of thing that has to be met first. And the other piece is rebates. Unlike generic drugs that don't have rebates, biosimilar drugs definitely do. And so, there's definitely opportunity there for the plan to realize some additional savings when a biosimilar, prescribing strategy is put forth. So if you go to the next slide. Thank you. I'm not going to go through this entire chart, so don't panic. But this chart's meant to illustrate that if you look at from 2013 to where we're at today over there to the right in 2022 and looking into 2023, that there's really an increasing pipeline and has been over the years of availability of biosimilars. Historically, most of these really benefited the medical benefit and specialty drugs that were used primarily through the medical benefit and in more of a hospital environment or an outpatient infusion type of environment. In 2022, when 2020, when Semglee, the biosimilar of Lantus, came forth, that really kind of started to initiate and revisit, kind of push this back to the forefront of the availability of biosimilars and the opportunity that presented to plans. And if you kind of fast forward now where we're at today and looking towards 2023, this is going to be this next year, 2023, is going to be a significant year for biosimilar conversion opportunity from the brand names like Humira and Actemra and Stelara. Humira itself is the #1 drug expenditure for most employers in the marketplace today. And so it's going to be really significant. We already have, 6 to 8, I think, biosimilars for Humira that are approved and ready to be launched once its, ultimate patent challenges and other things expire and they're able to hit the market. It's going to have a big impact on the market. So those are the things that we want to, really focus on and talk about. So if we go to the next slide. There's a lot of opportunity here because of these alternatives. And 2023 is going to be a big catalyst year of really providing a lot of financial savings opportunity for plans in leveraging the availability of biosimilars, particularly the Humira and the Stelara biosimilars, because they are very commonly used today from a specialty drug perspective. There are direct-to-consumer advertisements for those drugs. We see the utilization of these drugs, as well as the conditions and areas where the FDA has approved their use continuing to increase. And so the spend of these drugs in relation to that just continues to grow. And so it's an exciting time. We look for the opportunity, and there are some estimates that came out in the American Journal of Managed Care earlier this year that said that there's an estimate that biosimilar savings could yield as much as $38.4 billion in savings through 2025. So this is immense opportunity for plans to kind of prepare and take action now and to discuss a biosimilar strategy, to have conversations with their pharmacy benefit managers around the prescription drug, approach that's going to be taken as these biosimilars prepare and are ultimately launched into the market. So if we go to the next slide.
And that quote is across the country, that 38.4 billion.
Yes. Okay. Yeah. And so here it's just kind of summarizing the things that I've already talked about, that, really just the Humira launch of the biosimilar coming next year. There are going to be interchangeable versions of that, which means they can be automatically substituted, the biosimilar for the generic. There'll be some that won't have interchangeability indication, but still just the number of generics to compete with the brand name product, we're expecting to see some real, financial impact, and in addition, rebates as well. So I see Sean had a question.
Yeah, I have a question that's sort of adjacent to this. So if you have a couple of sort of final comments, because I'm gonna sort of bring up a new topic.
Okay. Well, can you hold your, maybe we'll hold those till the end. And when
Sure.
Janine goes through the PEBB specific information, that might generate some additional questions in alignment with what you're, thinking about maybe.
Yeah, sounds good. Yeah, as soon as you sort of hit a moment,
Okay.
I'll jump in. Yeah.
Okay. So these are just, from all the stakeholders' perspectives, really just, outlining the different things that biosimilars offer and what that looks like, and what's being discussed now. I think, the biggest ones are obviously financial, but I think if you go over to the right there and look from a patient's perspective, there's going to be potentially, some questions that are going to come up. What's going to happen to Humira's patient assistance programs that some people may utilize? What's going to happen at the pharmacy point of service for some of these biosimilars that aren't interchangeable, and physicians have to be contacted and those types of things? And probably the most important question, especially with the Humira biosimilar, is the stability of that supply, because we expect the demand to be enormous, and the stability of the biosimilar supply is really going to play into whether or not the pharmacy benefit managers are going to make decisions, how they're going to make strategic decisions about preferring or not preferring, certain biosimilars, one versus the other. So a lot of questions out there, but yet a lot of opportunity as well. So I'm going to take a moment and just transition quickly to gene and cellular therapies, kind of talking about those. If you can, thank you. Go ahead and go to the next slide. So the gene and cellular therapy space has really been on everyone's radar ever since Zolgensma for spinal muscular atrophy, which I know PEBB experience did have a member that required that $2.1 million drug therapy. And so we're continuing to see these $1 million therapies arrive in the marketplace. If you look over to the left there, just in the last 2 months, Zynteglo, which is for beta thalassemia, it's a rare blood disorder, was approved in August. It's going to be actually available for prescribing starting in the 4th quarter here. And then Skyzona was, which is for a much more rare neurological disorder. It was approved last month, and that price tag is at $3 million. So we're continuing to see these extremely innovative and in some cases considered curative types of gene therapies available, but at these enormously high price tags. And a lot of plans are really continuing to struggle with preparing for those types of therapies and or being impacted by them. So the thing to consider here is that this isn't going away, because as our technology continues to improve and all this research and innovation continues to come forth, the FDA is kind of anticipating, if you look at that last bullet at the bottom, that, by 2025, it's expected that on average, the FDA will be reviewing between 10 and 20 of these gene and or cellular therapy type products with these very high price tags. So it's going to become much more mainstream. And also, they're in the pipeline right now, what we're seeing is for more rare disorders, but in the pipeline, we're starting to see gene and cellular therapies, for more common conditions, or especially for gene therapies, where right now they're really, much more rare conditions primarily that they're treating. So the likelihood a plan is going to experience one of those claims is much smaller. As this moves forward, it's just the probability it's going to become something that's more frequent definitely exists. And so there needs to be some, planning and preparation for that. So if we go to the next slide, before I transition this off to Janine, and she talks about the PEBB kind of forecast around some of these products. This is where these gene and cellular therapies kind of sit today. If you look at the top there, there really is a lot more of a focus of identifying centers of excellence where members are required to obtain their care because of some of the uniquenesses of these treatments. There's also some challenge and some limitations in how do we identify future risk in relation to the gene and cellular therapy pipeline in relation, to current member medical conditions and that sort of thing. So we're seeing a lot more efforts, kind of being put forth to try and identify things as best as possible earlier versus later, so that these conversations about these novel therapies can begin early on versus when a prescription and a member condition and need arises. Specialty pharmacy really has made some adjustments as well in how they're delivering care to individuals that might require these special therapies. So here in that second section where it talks about specialty pharmacy, we're definitely seeing, I think the biggest thing we've seen is increasing adoption of member copay and assistance programs, leveraging every dollar possible from the manufacturer has really been kind of a forefront strategy right now for groups to kind of mitigate some of these cost escalations that they've seen. We are seeing also that coverage restrictions right now, being like, prior authorization requirements and things like that, are still less common. When you get into the higher cost drugs, there's typically is a pre-certification or prior approval process that's required simply to confirm that the condition, absolutely aligns with the FDA approved labeling and requirements. But it still is a relatively, we don't see therapies excluded all that commonly in this particular area. And then the user experience, that there really has been a expansion and a growth in the area of providing high-touch member-centric models so that they're understanding their conditions, really helping members, walk through that whole entire process so it's less stressful for them. And we have seen member specialty pharmacy scores continuing to improve, and I think a lot of that has to do with the high touch models that are involved. So we've definitely seen some changes here that are reflected in the slide in the marketplace as a result of specialty pharmacy growth and the influx now of gene and cellular therapies in preparation for what's coming in the future. So with that, I'm going to take a pause and introduce Janine Statt, who I mentioned earlier. Oh.
Yeah, if like maybe this is a moment where okay. I can sort of jump in there as we're sort of handing off the baton, and then maybe my question might prompt a little bit of discussion as we start going through the next slides. So my question is really combining two things. Previously in this meeting, we heard about the success of 1067, the so-called hospital cap, right? And the idea of that was attaching costs to Medicare. And it occurs to me that recently there has been federal legislation that has taken some action on insulin costs for Medicare. So now my gears are turning to think, I wonder if there is an opportunity to do a similar thing, but this time with pharmacy, attaching costs to Medicare. And so insulin in particular is I feel like a ripe area to have intervention, political intervention, because it is the quintessential example of the free market failing, because it is 100-year-old technology, basically. I mean, they tweak it, but it's basically 100-year-old technology. But the free market keeps pretending like it forgot how to make it. And so every few years, like, wow, this is so new. It's got to be really expensive. And that's, nationwide, we all seem to accept that. So much so that California has actually taken the tactic, their equivalent of PEBB, has taken the tactic of actually just building its own insulin plants. They're just going to make their own, because it's actually not that hard, because it's 100 years old. And they're just going to supply themselves because it's so outrageous. So my question, I guess, is, have you heard of other states, some policy questions here in particular around insulin? The biosimilar conversation is also very interesting and productive because at least the free market is apparently responding to some of these outrageous costs. But for insulin in particular, are you aware of other states starting to take the strategy, at least other state benefits like PEBB, coordinating with California to just like purchase from them, or some kind of coordination with California when they're doing this this creation of their own market essentially? And then second, do you have any preliminary thoughts about some kind of similar strategy legislation of just like attaching PEBB costs for insulin to a federal benchmark such as we did with 1067?
Okay, so there's it was packed a lot in in that commentary and the question. So I'll do my best, to address this. Keep in mind that I am not a policy person on our pharmacy team. I'm happy we can do some follow-up and provide some specific information. I am aware of what is happening in California because I do handle the West market. I can speak to the fact that there are other states across the country. I think there are 7 or 8 now that have insulin legislation. I know Colorado and Washington, because I deal with those states, do have insulin cap legislation. Not all of them apply to self-insured plans. Some of them only apply to fully insured plans. There are all kinds of variations of these that go on across the country with regards to what populations they're applying to. We are seeing some trend, it seems like around that $35 a month cap seems to be the sweet spot, if you will, in most of the coverage costs that members would experience versus traditional plan setups and things that we see today. I would also say that we are in the PBM space, in the pharmacy benefit manager space. We are seeing some PBMs offering a diabetes type solution where the cost of insulin can be addressed, but oftentimes that also requires that specific manufacturer insulins are utilized when you do that type of a program. In other words, whatever's on formulary, if there's something that's not on formulary, those types of reduced copay type of a program wouldn't apply. In those situations, it's typically the plan itself that is absorbing some of that cost differential, and rebates help set off some of that cost as well, because insulin is a highly rebatable category. I would not be the most appropriate person to speak to whether or not it makes sense for other states to try to tag on to what California is doing with regards to setting up and manufacturing some of their own products. I a lot to understand with regards to that legislation and really what the requirements are, and their ability to get the licensing and the approval and all of that from the FDA for the plants and things that would have to happen. I'm not sure how far down the road that would be. I think it's something to continue to monitor. I had heard discussion that there were some other states that it was in a legislative blip that I just happened to read, that there were a couple other states trying to look at either partnering with California or considering to try to maybe do something like that by themselves. I think the crystal ball I don't have in that regard. I think it's something to keep an eye on whether or not that is feasible for the cost and all of the licensing requirements and things that would have to happen to kind of become your own manufacturer. I know Mark Cuban drugs, they're, you know, low cost drugs. There have been some interest in their manufacturing. We'll just have to wait and see what some of that, you know, what areas they may look at, and if they're going to start reaching out to some groups and public entities and things to offer reduced drugs at reduced prices. It's really in its infancy right now. I think insulin's kind of started that conversation, but I think there's just a lot more to understand, and being able to put all the appropriate pieces together to kind of address this. And right now we're seeing just individual states kind of trying to do it, you know, a PBM or two, at least are offering solutions for plans that are interested in doing something to kind of cap those amounts or to address the affordability. There just isn't one golden solution right now.
Yeah, well, thank you for your response on that. I mean, this is clearly something that needs to be an ongoing conversation. I know we're running short on time. You wanted to finish up your presentation and hand it off to someone else.
Yep, so I'm going to go ahead and let Janine walk through the final two slides. So thank you.
Thanks, Kendra. And excuse me, I'm just checking to make sure everyone can hear me okay. I switched audio.
Yes.
Great, thank you. All right, so what we're going to go through really quickly here, I know we're running short on time, is a list of recently approved and soon to be approved gene therapies that we reviewed for PEBB. And Kendra covered most of the topics specific to gene therapy already. You know, very high cost, very few members, very rare conditions, so a little bit harder to predict, but potentially curative. So we kind of look at these drugs and this spend in context with those features of gene therapy. So the ones we have here, I'm going to orient you to the slide. On the far right, you can see a member review. That's the column where we listed out some potentially eligible members if we found them for the gene therapy listed. We went through the data, looked at their diagnosis codes as well as their drug spend and some medical data to see if we thought that they would be potentially eligible to receive that gene therapy. And then the rest of the slide, from the left to the right, you'll see the condition treated, which gene therapy we're talking about, the projected cost of the gene therapy, and when we think it will be approved. And a couple of them have been approved recently, so we've listed those dates there. We'll take a couple quick examples. The first one, Zolgensma, I think that was also mentioned previously, for spinal muscular atrophy or SMA. We've listed the prevalence there. I know there was one utilization not too long ago for that therapy. Typically, there's different levels of SMA, whether they are on the less severe range or the more severe range. Usually the more severe forms is the one that you're going to see for the gene therapy Zolgensma use. We didn't see any diagnoses for that, but again, these members are typically diagnosed at birth, sometimes within the birth screenings that they do for new babies. And we don't have any members identified there, but again, one of the things that we would recommend would be monitoring the birth rate as well as those new diagnoses that come over during newborn screening. The second one here, we'll use as an example. Zynteglo, also recently approved for transfusion-dependent beta thalassemia. No members were identified, so nothing to discuss here, but it's a good example because although a member may have a diagnosis and an eligible severity level, meaning they have transfusion dependence, they have 8 or more blood transfusions a year, the members that would have that may not choose to do gene therapy or may not be eligible for gene therapy. For a few reasons. They may be stable on a current regimen for their condition. They may be, or their providers may be concerned about safety and long-term efficacy of the gene therapy. And then last but not least, a certain percent of those members that could be potentially eligible may ultimately be deemed ineligible once they undergo further screening. So there's usually a rigorous authorization or pre-certification process where they look to make sure that they don't have any disqualifying conditions or genotypes that would render them ineligible for that gene therapy. So those are 2 examples of drugs that are currently on the market. We don't have any members that we've identified. The last one that I wanted to go over, which we have one more slide for with some more detail, is hemophilia A, because we did find a couple members that might be eligible for the therapy. I want to discuss some of those details in more detail. So is there any questions on this slide before we move to the next one? All right, if not, let's move on to the next one. So what we do is we look at the diagnosis codes, the medical claims, pharmacy claims for members, and there are several members that are diagnosed with hemophilia A, but hemophilia, just like other conditions, have severity levels. Some may have the condition but may not utilize the blood factor treatment that is usually what is the staple for treating this condition. And some may be on the more severe end where they're receiving 200, 300, $1 million a year worth of blood factor treatment to maintain their coagulation. So for Roctavian for hemophilia A, we're projecting it to cost in the range of 2 to 3 million for a one-time gene therapy treatment. This was previously set to be approved a couple years ago, but the FDA delayed it. They wanted to see that the gene therapy is not only effective and safe, but that there's some long-term or longer-term efficacy that doesn't wane over time, so that by administering the gene therapy, the goal is to be curative and the goal is to reduce that very expensive blood factor cost on an annual basis. And they wanted more data to show that it maintained its ability to do that. So we have the prevalence listed. We also have on the previous slide a couple of, what we found for how many members had that condition and have high utilization. The gene therapy is likely to be approved for or have a requirement for approval of the more clinically severe members. You don't necessarily set a cost threshold, but the more severe members tend to have very high spend. And so we looked at those members, the two that are within the age range and severity level, they are spending about $500,000 a year on either blood factor or Hemlibra, which is similar to blood factor, in most likely preventing bleeds, just having an ongoing basis of that therapy. And if we were projecting, which again, it's hard to do a projection when you have two members, but typically when members are screened for eligibility for gene therapy in like the clinical trials, there are certain factors that members have or patients have that will render them ineligible. So for this one in particular, there is a factor in their body that can make that that vector that inserts the gene into the body, make it inactive. So it basically makes the gene therapy not active in that member. So if they have that, they would be excluded from getting the treatment. So those types of factors, about 50% of people have a combination or one of the factors that are listed as exclusions. So we would assume maybe one would be ultimately truly eligible. And like I mentioned in the slide before, again, if someone is stable on a therapy and comfortable with their regimen and not having any, hospitalizations or things like that, they may choose to stick with their current regimen rather than seek gene therapy. And like I mentioned before, the cost offset. So, 2 to 3 million is probably going to be on the higher end of what the gene therapy ends up costing, but the cost offset would be at a minimum the $500,000 a year that these members are currently spending to treat their bleed. So the assumption is once the gene therapy is administered, the rates, the amount of those therapies that they'll need will drop off pretty significantly, theoretically down to zero or close to zero, and they would have no drug costs in the future for at least the next 5 to 8 years. So that is our review for the PEBB members and the list of drugs that we have on the slide before. This is really the only one that may become of concern or may be worth monitoring. Not necessarily this drug, but other drugs and other manufacturers are venturing into a negotiation for costs, potentially offering like a refund or rebate type for therapies that are not effective, that don't reduce the cost of the other therapies needed. Not necessarily Roctavian, but there are those discussions being started, and so it's a good place to be for those discussions.
All right. Well, thank you both. I know we're getting squeezed on time here. And we've got 3 more presentations on pharmacy. Just want to let folks know that we're not going to do the innovation work group update today. And we do have public comment today. So we're going to do our very best to wrap up by 12:30. If that means we have to cut one of the pharmacy presentations and do it at the retreat, we may have to do that if we're not making it through the pharmacy presentations. I know it's information everyone wants to hear. I will ask our presenters to keep to time as much as possible. And so I believe I'm handing it over to Helen. Is that right? Helen Noonan-Hernsberger from Providence?
Yes, hi, good morning.
Good morning.
This is Helen Noonan-Hernsberger, and we'll go through these slides as quick as we can and then make sure we answer any questions afterward, primarily, I would think, but always happy to answer your questions. So I'm Helen Noonan-Hernsberger, Vice President for Pharmacy at Providence Health Plan. Today, my team is going to review with you our total cost trends in pharmacy, our brand and specialty drug cost and utilization trends, focus on diabetes therapy trends, inclusive of insulin and other newer therapies, an overview of some of our pharmacy program highlights, and just a very brief slide on gene and cell therapy that corroborates what was just presented. And then you asked for a little bit of information on COVID-19 testing trends. So with that, I'm going to introduce you to Heidi Chinwuba and Gina Korab, who are part of our team, and we'll take it from here. So Heidi?
Yeah, good morning. Thanks, Helen, and good morning, everyone. You can go ahead and advance to the next slide for us. Thank you. I'm going to start by doing an overview of total cost trends on the retail pharmacy side for the plans. We're going to look at the plans broken out, choice in the blue bar or the left-hand bar, statewide is the middle or green bar, and then the combined trend is the gray bar there on the end. So this is a 5-year trend and really overall pretty favorable in the single digits. So I know pharmacy is a bit of a different animal, if you will, when it comes to costs and all of that, which we've talked about in detail over the years. So overall, the statewide, the choice trend has been 7% over the last 5 years. But on a lower base, you'll notice that the choice costs from a pharmacy perspective are lower overall as compared to the statewide plan. The statewide trend at 5% over the last 5 years and really flat over the last 3. And I will call out that if you actually exclude the COVID vaccine costs, which are included in this data from the statewide trend, we would have seen a negative trend in that population. And overall, then a combined trend of 4% over the last 5 years, and really, again, has remained stable over the last 3. Just a quick note about COVID. Again, we do see costs for COVID-related vaccine administration fees, as well as more recently Paxlovid, the antiviral administration administration costs in this data. And it ranges from 50 cents to about $1.50, depending on which year you're looking at. As we move out of the pandemic phase, vaccination will continue to be recommended for certain populations and will become an annual expenditure that we see. We won't see utilization probably as high as it has been in the past, but we will see unit costs increase as the government subsidies for vaccines and other therapies end, and that those costs increase due to just, general market dynamics. So something that we'll be watching, making sure that people get the therapies they need there. So next slide, we're going to dig into just the breakdown of the medications by how we look at medication utilization and cost by generic, brand, and specialty. So Kendra did a nice job of kind of highlighting some areas that we're going to be looking at specifically here. And I'm going to look just at choice today in the interest of time, as well as that's where we've seen the trend. We are seeing, as noted, a persistent increase in specialty drug costs that we expect to continue. But as highlighted, there is some light at the end of the tunnel with biosimilars and other programs that we're putting in place for 2023, like the Copay Maximizer program, that can provide some cost offset in relation to the specialty drug costs. The 3 main categories of spend are noted here. It's the dermatologic category, which includes a couple medications which have several indications. So beyond, you might be surprised to think we're spending $5,000 or $6,000 a month to treat dermatologic conditions, but the 2 medications listed here have indications in asthma as well as inflammatory bowel disease that cross over. And so that's what's driving much of the spend. Also some increase in the endocrine category. Specifically, there's some increase in costs from the expanded benefit on fertility that we're seeing come into play in 2022, so not surprised there. And then an anti-inflammatory, just continued utilization increases for the anti-inflammatory medications used to treat rheumatoid arthritis, inflammatory bowel disease, psoriasis, and other conditions. But again, with those biosimilars on the horizon, we do anticipate that in 2023, or certainly by 2024, that this specialty trend should hopefully level out and not continue with the trends we've seen of late. In the brand category, the increases are smaller, primarily centered in the diabetes category, where we're seeing newer branded medications with better outcomes for better long-term outcomes related to cardiovascular benefit and other benefits. And we'll go into that in detail in a few slides. Go ahead, the next slide. In this slide, we're looking at the top 3 categories of spend for the specialty class, and this is just ranked in order of spend. So we see, again, the anti-inflammatory medications, Humira and Brel, which I reviewed, the dermatologic again, and then cancer also. So what you see represented by the bars is the total cost per prescription for the therapy. So what we see in both choice and statewide is that by and large, the total cost per prescription in each category is pretty stable. It bounces around a little bit, but the costs are stable, which you would hope because they're already very expensive to start, right? We're seeing $5,000, $10,000 and more dollars per script in the case of cancer. However, what you notice is represented by the lines is utilization. So we're seeing significant increase in use of these therapies due to the expanded indications for them, the expanded treatment of conditions for which there perhaps previously wasn't a great treatment for. And so that's really what's driving the overall cost. It's not necessarily the cost of the medication itself, but rather the use of the medication in general. And if we go on to the next slide, we're going to look a similar view, but we're looking here at non-specialty branded medications. So again, focusing on the primary category of spend here being endocrine, which includes the diabetes medications, as represented by the blue or the bottom bar. And then CNS medications, which central nervous system, that includes medications to treat things like migraine. So there's new groups of medications to treat or prevent migraines, as well as branded products to treat attention deficit, ADHD. And we've seen an increase, I believe, in prevalence and treatment of ADHD, certainly since the pandemic, as children in particular have returned to school. We've really seen a fairly dramatic increase in utilization of those medications. And so that's what's driving a lot of the trend there. And then a smaller increase, but steady still, in medications, the branded medications used to keep the blood thin in cases of atrial fibrillation or blood clots. And sometimes reflective of just a trend towards preference for those medications, as well as general aging of the population. So moving on to the next slide, we're going to look specifically then at diabetes medication trends and just look at what we're seeing there, because this is an area where we're also seeing some pretty significant shift in utilization. So we're looking at branded products here only, and you'll notice that insulin is not on this slide. That's on the next slide. We'll get into that. Insulin is no longer really the primary cost driver for most patients in diabetes care. And again, I'll get into that. We're really seeing these newer products for the treatment of type 2 diabetes specifically that have outcomes data. So not only do they lower blood sugar, but they have evidence that they can prevent major cardiac events in patients with diabetes, as well as in patients with comorbid conditions such as heart failure. We're seeing decreased risk of hospitalization and adverse events associated with that. So in particular, this green bar on the right is the class of medications known as GLP-1 agonists. This is a class of medications that also is found to be beneficial because it promotes some mild weight loss, mild to even more significant, in some cases, weight loss, and has long-term benefits in its use. And then on the left, you can see the significant increase in use of that medication is represented by the top line. So pretty steep increase in use over the years. Importantly to note is that we are seeing improved diabetes control with use of these new medications. So you wonder, we're spending more, are we getting the outcome that we'd hope? And in the case of the Providence PEB and statewide plans, the answer is yes. So the choice plan is in the 90th percentile for HEDIS performance for A1C poor control, and the statewide plan is in the 70th percentile. And the PEB, the choice plan is the best performing PEB plan overall. So good to see those outcomes associated with that. We also have seen, as we introduced VERTA this year, the nutritional support and counseling support program for diabetes, for high-risk patients, we're seeing continued uptake in that program each month. And we've seen significant decreases in A1C as well as medication utilization associated with that program. So I'd like to continue to promote that. And as we see enrollment, hopefully see some stabilization in some of these numbers. Talking a little bit about insulin, there's a lot to unpack about insulin. We've already touched some of that. Wanted to just show a few graphics here. On the left, we're looking at insulin kind of costs over the last 3 years. Now, if we were to go back further and trend insulin costs kind of per unit over a decade or more, you would probably see a different trend. But at least over the last 3 years, things have stabilized somewhat. We are showing graphics here for the top bar, which is just kind of insulin cost per unit before a rebate is applied. The blue bar is actually after a rebate is applied, where we actually are seeing now insulin costs trending down. Kendra mentioned those rebates are substantial and they are going up as biosimilars and competition enters the market. So we're seeing costs overall for insulin, at least on a per unit basis, go down. And of course, for the PEB population, there is no out-of-pocket cost for insulin. And in Oregon, we have the cap in place. So this is something we're watching very closely regarding the comment about California manufacturing insulin. I would also just note that Civica, which Providence is a founding partner, is also looking to produce insulin in the next couple of years. And whether those products actually pan out to be less cost, I think is noted, remains to be seen. Often what we see is the rebate might go up just to kind of match whatever the market might be. Those rebates don't help patients who don't have insurance, but at least for the PEB population, this is something we're certainly keeping track of. And then notable on the right is just that insulin use in the treatment of diabetes in general. Type 2 diabetes is really second or even third line. It's falling out of favor because of some of the medications I mentioned on the previous slide. Certainly, obviously, the only treatment in patients with type 1 diabetes, but overall, we're seeing a decrease in use. There's a lot more we can unpack there in the future, but in the interest of time, Helen, it looks like you might have a comment. So I'll pause to.
Well, at least on my slide deck that I'm watching along with you, it didn't advance. So I was wanting to just let Rose know to advance the slide.
I forgot to give the cue. Can you tell I'm like
double? Yes, it's okay. Sorry, I did interrupt.
Sorry about that. Well, here we go. So you can look at this at a later time and we can talk about it, but I want to keep us moving since my little timer tells me here we're running out of time. So you can actually go on to the next slide now for us, Rose. And this has been just taking a moment to spotlight behavioral health medication use. Again, another area that we're focusing on. We've seen consistent increases in use of, as I mentioned, ADHD medications there in the middle, antidepressants and anti-anxiety agents over the last several years, the 10% increase in the use of antidepressants just in the last 2 years, and a 30% in the increase of use of stimulants. So again, focusing on those quality metrics, looking at patients who start and then continue on therapy, we see fairly good adherence in both of those in the antidepressant HEDIS metric, and then just continuing to encourage use of our behavioral health concierge platform as an access point for patients through telehealth visit to receive care that they might need, including prescribing of medications if appropriate and when appropriate. This is an area that we're focusing on. Many of these medications are lower cost or no cost to patients, so that's good, but wanted to just share what we're seeing from utilization from a behavioral health perspective. At this point, you can advance to the next slide. I'm going to turn it over to my colleague Gina, who's going to finish us up with some just savings that we've seen for the PEB population related to our programs. Thank you.
I'm not sure
Gina,
the
I think you're
audio is
muted.
working. I still don't hear you. Not hearing any
Not
audio.
working. I'll go ahead and take it and we'll see if Gina can get on here in a minute. So here we're just highlighting again, Kendra talked about this, but the biosimilars, we made a pretty, a lot of shifts to biosimilars on the medical side in 2021, where there were several products available. Gina, just give me the thumbs up if your audio starts working. Specifically for oncology products and Remicade, so over $1 million in PEB specific savings in 2021. Really closely watching the entrance of the Humira biosimilars in 2023, and we'll wait to see how that kind of all shakes out with pricing, but certainly making sure that all of the players, the patient, the provider, the payer are kind of aligned in strategy there. There's a lot to consider, which Kendra nicely laid out, and that's something we actively are working on a strategy around. Another area where we've been able to see cost savings for specialty, at least, is the introduction of specialty generics. So particularly in the oncology space, we've had several new generics that have come to market, and really just watching the price of those closely and dropping them down to what we call a MAC price, or a maximum allowable cost, as soon as we can. We find that when we compare prices for the PEB population through Providence to, you might have heard of the Mark Cuban Cost Plus Drug Company is out there and marketing a couple of these medications. Were very close in unit cost, if not better, in a few categories. So those are nice new benchmarks to see a lowest cost aligned entrant into the market that we can kind of benchmark against and show that we're doing our diligence there. And then just expanding our site of care programs, which we've had for the last several years, to continue to add facilities as well as medications to make sure we're aligning to really, Senate Bill 1067 Medicare-based pricing for medical drugs in every area that we can. Next slide. Gina, I'm going to check in to see if you have audio yet. I think we lost her entirely now. She's not on my screen. So I'm not going to go into this too much because we had a nice discussion on it with Kendra and the Mercer team, but again, focusing on the impact of gene and cell therapies for the PEB population in particular, making sure that we're identifying medications early in the approval process, monitoring who of the PEB population might be appropriate for those therapies, providing communication and budget impact to Mercer, and therefore the PEB team when those patients come onto our radar, and then really coordinating the contracting, the delivery, kind of the whole wraparound services related to delivery of the gene therapy that was talked about, and including pricing, which was mentioned, Medicare-like pricing. We really do these on a case-by-case basis, as well as outcomes-based agreements, making sure that those milestones with either remission or cure are met before anything is paid, and just having a whole strategy focused around that is something we're actively working on. And if you go ahead and go to the next slide, we have a very similar slide to what Mercer shared, just looking at prevalence for the PEB population for the various medications. The only thing I'll add here is that we also included what's known as CAR T therapy. It's similar to gene therapy, specific but slightly different in its technology, specifically used in certain cancers to treat. And we have had a few PEB cases of CAR T therapy. Those are less expensive at around $500,000 a year, at least for the drug and their treatment. But we are seeing pretty rapid growth in indications for these medications, and expect more patients to qualify for this type of therapy. That we are seeing really cancer remission rates for up to, I want to say 5 to 8 years at this point for multiple myeloma, which is outstanding. And again, same strategies around center, care coordination, contracting, pricing, etc. there. Gina, are you with us? No, she's still not there. So I'll go ahead and wrap us up.
I was going to say that there was a suggestion in the chat to try *6.
Is that like a quadruple mute? Because we can triple mute ourselves at Providence, and that's like a 4th mute option.
I don't know. Go ahead and finish up. It sounds like.
Yeah. So this is just a highlight on, again, as we COVID at home testing, we were asked to kind of give a brief, share the differences primarily between cost and utilization of the PCR versus the OTC test. So certainly when clinically indicated or appropriate prior to surgery or travel or whatever the case may be required for having a documentation of a negative COVID test, PCR testing is still sort of the preferred methodology, but the cost for that test still tenfold what we see now for the reimbursement rate for the OTC test. So just wanted to highlight the availability, widespread availability of options to get OTC COVID-19 home tests, specifically for us through the Costco pharmacy website. Oh, next slide. Thank you. So through Costco website, you can get really easy to get those OTC home tests at a low cost. And we're seeing pretty good uptake as indicated by the chart on the right of the COVID-19 OTC testing. Members appear to be accessing that and utilizing it with over 25,000 tests accessed since the beginning of 2022. You can see how the spikes there align with different spikes we have in COVID. But want to just bring it to a close since we're over time and see what questions you might have. Thank you for your time.
Right. Well, thank you so much, Helen and Heidi. And sorry, there was audio trouble for you, Gina. So I do want to ask if Dr. Bachman, if we can move the Kaiser presentation to December. Ollie, let me know. We should have plenty of time in December to hear the 3rd pharmacy presentation, which would allow us to give you adequate time and hear MODA today.
That would be completely acceptable.
Okay, thank you so much for your flexibility on that. All right, so we have Katie Sheeler from MODA.
Hi, everybody. Can you hear me okay?
Yes.
Okay, I take that as a yes. So I will be quick. I want equity amongst all, and I know there's public comment, and that's very important. So I'll be brief. I'm Katie Sheeler. I'm a pharmacist by training and a senior clinical program manager at MODA. I'm going to move through the slides pretty quick, as I say. So the next one is an overview, and we are going to hit upon our recent program updates, the PBM transition to Navitus, MODA 360 enhancements, and then a future program consideration. Just to note, this does not cover all of the clinical programs we have in place, like high-cost generic, pharmacy benefit optimization, specialty light. This is just honing in on just a few of the mini programs. Thank you, Rose. If you want to go to the next slide on site of care. So we've talked in the past about site of care. This specific program was launched in 2017, and it was implemented because specialty infusion drugs, we see costs double in the hospital outpatient setting when compared to home infusion or provider offices. We also see administration costs can be up to quadruple when these infusion or injectable medications are given to members. These are medications that are billed under the medical benefit and must be provided by a healthcare provider. So these are not ones that are self-administered. This program specifically works through our prior authorization process and really directs members towards most convenient sites of care as well as the most cost-effective. So we implemented, as I said, in 2017, but then we had a phase 1 expansion where we moved into medications utilized for supportive oncology medicine. So this is not the therapeutic cancer treatments. These are the medications used to support those who are on chemotherapy. They're often given on different days of the actual chemotherapy. So members typically go back to the hospital or infusion clinic to get these specific medications. And this particular program reminds them that they have options for home infusion or, maybe better access at their provider office. So the savings that we've had to date through August of 2022 is approximately $62,000. That's for 14 members. And again, dollars are great, but this is also a really great service to members. We hear, gosh, it's so much more convenient not having to go to OHSU up on the hill and find parking, or I could be in my home and have these in private. On the next slide, I'll hit on biosimilar management. And Kendra teed this up nicely as she talked about this being an emerging class and a great opportunity. We totally agree. We are trying to keep ahead of the pipeline, and so we saw the biosimilars coming. And in 2019, we enacted our biosimilar program. And we have two different categories. One is those oncolytics or cancer treatments that are available as biosimilars, and then those that are other therapies like the insulin that has been mentioned. So again, these medications are covered under the medical benefit. They are not all self-administered, though some like the insulin are. And just a quick refresh, these biosimilar approval pathway determines when drugs are highly similar to the reference product in both structure and function, and the output of safety and clinical effectiveness. So they're really great alternatives to the expensive brand reference products, similar to generic medications, but a different pathway, as Kendra explained. So through August 2002, the total amount of savings we have for the non-cancer biosimilars is $41,000. That's been for 33 members. We also wanted to bring forth the approximate cost savings for the oncology biosimilars, and that was through end of 2021. We had the numbers, and that's about $83,000. But since we've had implementation of this program, we've seen provider community uptake, biosimilars and start feeling comfortable and starting to prescribe biosimilars without us, asking the question if they would consider it. So we really expect annual savings to grow as more people shift to biosimilars and as more biosimilars come to market. On the next slide, apologies if I'm talking quickly. Simply Health, so as a reminder, this particular program is in place for members who are taking certain brand medications for which there are no generics available. These are certain cardiovascular medications. And what this is the members who are taking those medications and had active claims, they are invited into the Simply Health program. And this really targets adherence. We know 80% or more, if you take your medication, it's really really works as intended. When people take the medication less than 80% of the time as prescribed, then they really don't see the therapeutic outcomes of that medication. And so we implemented this program to support members adhering and taking their medication, but really wanted to give back to them. So this is a text-based program. It uses the point of service prescription discounts. It gives members dollars off of their refills if they refill on time. So it not only helps decrease their out-of-pocket amount, it improves adherence, which can decrease downstream effects of medical costs if their health is not taken care of as expected with the medication. So on the next slide, you will see the outcomes, and these are PEBB specific. So really enrollment is pretty simple, engagement is great. We saw results at the end of September 2022 that the enrollment rate of everyone who was invited into this program taking those medications, we had 41% of the eligible people enroll, which is a very high number. There were over 653 total fills with Simpray within the year. 95% of them were on time. $18,500 was saved collectively on member copayments, and the average discount per fill for a specific member was $29 off of their copayment. And then when we look at those who are enrolled in this program, a PDC is proportion of days covered. It's an indicator of adherence. So those who were adherent of 80% or more, people were 36% more likely to be adherent when enrolled in this program than when not enrolled in this program. So great generation of benefit for our members, but also for the downstream costs so they can keep their health well. On the next slide, I'll touch on our drug wastage program. This one, again, is also for medications under the medical benefit. This aims to limit wastage of injectable medication. So this really is vial size. And when providers prescribe a specific dose, sometimes the next vial size has, 8 mils more than what is needed. And so that vial just gets wasted and thrown away. So this specific program really looks at how you can round the vial and combine them as such, so there will be minimal wastage. We won't be throwing away as much product. That product gets billed anyway and gets paid for and then tossed. And so I won't get into the specifics of the studies on how we round up, but this is a recommendation made to providers during the prior authorization process. And if a provider agrees to dose optimize with the vials, then they go ahead and change the order. So through June of 2022, this year, we've seen about $54,000 of savings just in this simple rounding and not throwing away drug that's already billed. Next, now this transition update. So at the beginning of 2022, we rolled from our previous PBM into a new PBM. We sent notification about formulary disruptions. We did all the work behind the scenes. We still celebrate today of this huge work that was done for this transition, and it's been relatively quiet. So I mark this as success. This is a really big undertaking, and we have not had member complaints about this transition to a whole back-end processing system of our PBM. So I'm really proud of that one. We have just a few slides on our MODA 360 enhancements. I'll let Erica quickly talk about that.
Thanks, Katie. Rose, one more slide forward. And again, sorry to keep repeating this, but I'll be quick in the interest of time. And really just want to take a minute to kind of show how we incorporate pharmacy into our MODA 360 program that really is looking at the whole member. And one way we do this to support pharmacy is through care reminders. So when members log into their member dashboard, if they have any preventive services that are past due, up in the upper right-handed corner, they will see something similar to this, which is a care reminder. So this is a diabetic, and this care reminder is reminding them about statin therapy. And the member can either contact the health navigator, and that'll bring up the phone number, or call them directly, or they can chat directly with the health navigator as well. Next slide. Great. And then our member dashboard that we are going to be rolling out an enhanced member dashboard in early 2023. This is a screenshot from the mobile version of that new dashboard. And we also support our pharmacy programs such as Sampre with our personalized programs. So here, if a member clicked on the MODA 360 programs, that would take them to the 3 programs that we have identified based off of all of the information that we know about the member, which programs could benefit the member the most. And our purpose for doing that is really because, PEBB and MODA together, we offer members a lot of different programs. Some of those programs would benefit a member more than others. So instead of giving a member a list of 30, 40 programs, we use all the information we have to identify the 3 best programs. So if a member were eligible for Sampre and hadn't yet enrolled in that program, then they would see that here listed. They could click on that program. This is showing an example for Livongo, which is a diabetes management program. And then it would give a description of what that program is. They could click on Learn More. That's going to take them directly to that program's website where they can enroll or get started with that program. And then, as always, they can chat with the health navigator directly from that site as well. Next program, Rose. Or I mean, next slide. And I won't read this just in interest of time, but this is just some member feedback from a PEBB member of a navigator helping them through an issue that they were having with their pharmacy. So I will leave that for your reading pleasure later on. Next slide, and I will pass this back over to Katie.
Thank you. And one more slide, Rose. Thank you always for advancing, by the way. So a future consideration that we'll talk a little bit more with the renewal, so I won't spend too much time here, is just the idea of a copay max plus program. And this is a program that utilizes copay accumulators. So this will be a 2024 benefit enhancement that we'll talk again in the future. But it's something that is applicable to over 350 medications, most of those specialty products. It uses copay manufacturer assistance programs to offset the point of sale costs for members out of pocket. And then it also allows for a true reporting of the member out of pocket costs that they actually have paid when they use the assistance from the manufacturer to offset costs. So a little dangle. It's been 13 minutes. I've taken enough of your time. Thank you for the opportunity, and I look forward to hearing from the public comment. So any questions? Thank you, everyone, for dealing with my quickness.
All right, thank you so much, Katie and Erica. And also thanks again to Dr. Bachman. We'll hear from Kaiser at our December meeting. Also, thank you to Sean Parkman, who is one of our board members, who is going to give the Innovations Work Group update. We will postpone that as well. And we do have public comment today. I know we have been hearing about access issues with both VSP and Willamette Dental. And I believe we first have Wednesday Martin with us, who is a PEBB member and would like to provide public comment. Go ahead, Wednesday.
Thanks for having me today. I just, make it really short. We have 2 providers left that will take VSP in Douglas County. We're a population of a little over 100,000 people in Douglas County. Many people are having to change doctors or go out of county to see a VSP and network provider. In my situation, this was not as easy a change as my son has Asperger's, and change is difficult. He had just gotten to the point where he was able to see his doctor that he'd been seeing since he was 7 years old, and he was able to see him on his own and feel comfortable. Our doctor stated that he was no longer in network with VSP, so we went to Costco instead. The doctor there was not considerate about Devin's processing speed. And when he was done with the appointment, he was left confused and unable to let me know what he needed, as the doctor had some recommendations for him. I had to talk with the provider then and have her explain what my son needed. I asked why they wouldn't accept VSP, and they said that they didn't feel fairly compensated for their services. I don't have a choice. I need to take my son to a provider that understands him and accommodates him. And that means we'll be paying for out of network with his previous provider. And I think it's important to look at how this is affecting people with disabilities as well as so many others. And I hope that we can see some change so that we can have more access to providers here in Douglas County for VSP. Thanks for having me today.
Thank you, Wednesday. And I also understand you emailed your public comment to Rose. So that will be shared with the board. Okay, thank you.
Thank you.
And we have 2 additional written public comments. I do want to double check with Rose. I don't believe either of them are here with us, so I'm going to summarize their public comment. Is that right, Rose?
I don't believe they is.
Okay. So we have a public comment from Tia Shattenkirk around access to Willamette Dental. That public comment is really focused in on with the closure of the Roseburg office and not having access in that area. They are looking at having to drive more than an hour to see a dentist with Willamette. That is a hardship for them. And then Jody Adams also submitted testimony. Her testimony is actually around VSP, Willamette Dental, and her experience at Curry General Hospital. The piece that I just want to emphasize around Curry General Hospital, I would just encourage Providence and MOTA to look at that, since I imagine our members who are covered by Providence and MOTA in Curry County access that hospital. Specifically around Willamette Dental, it is also similar to what Terry highlighted. There are access issues. There's a long way to drive to get to see a dental practitioner. And then for emergencies, then she was having to go through multiple appointments. And so that having to drive a long distance for multiple appointments is challenging. And she also talked about vision care, having access to a particular provider that is no longer taking VSP. And so having to deal with the higher costs. So I just want to encourage folks to read the public testimony. I know that we've been having conversations with VSP, with Willamette Dental. Those are things that we are going to have to talk about as a board as we move forward. Also, you know, something that we'll be leaning on Mercer to talk with us about any ways we can try to troubleshoot so that folks are having access in our rural areas, since that's something we have definitely identified as an area that we want to make sure that all over the state people are able to access their benefits. And Ollie or Damien, did you want to make any comment on this?
Well, I think you captured it perfectly, Siobhan. I think, you know, we want to make sure that everybody has access to the care and services that they need. And there's definitely certain parts of the state where we're struggling more than usual. I don't know if it's a byproduct of the coming out of the pandemic, but it's something that is going to be the top of the list on the renewal that we'll be discussing probably really starting next month. And whether that looks at plan design or other kinds of changes that we can make to ensure that those folks do have access, then we'll do what we need to do.
Go ahead, Andy.
Oh, I just wanted, again, being fairly new to the board, I'm not sure, is it possible to ask Mercer or find out these providers that no longer take VSP and whatnot, what insurance they are taking? Because, you know, it might be helpful to know if they are taking or what insurance they are taking.
Yeah, and we've actually worked through these areas to see what type of access is available. And oftentimes in some of the areas that don't have a lot of competition, they kind of make their own rules, so to speak. So that kind of leaves us in a difficult position and leaves our partners in difficult positions. So, but we'll reach out to the members, and you know, there's certain things that we can do that will help them get the services that they need.
Thanks, Ollie. So I know we've gone a few minutes over. Appreciate folks staying on. And again, in November, we have an in-person retreat. It'll be at Salem. At the Salem office where we used to have our in-person meetings. We'll make sure that details get out about that. We'll finish up our pharmacy presentations in December. And good to see you all today. We are officially adjourned. Thanks, everyone.